Morning, good afternoon. Good morning, good afternoon.
Okay, now I'm okay. Morning.
Good evening, depends where you are, and thank you so much for joining this session with the Public Health and Epidemiology Interest Group, the physical activity section of the American Public Health Association, as well as with America's Network for Chronic Disease Surveillance, the Florida International University, and the Universidad de Antioquia in Medellin. So it's a pleasure seeing so many here today for a webinar. As you've seen, we have a very interesting program with four speakers and from different continents. We have Dr. Lindström from Finland, we have Dr. Ajner from Colombia, and Dr. Sawu from India, and myself, and I'm based in the US. And the order of presentation will be first, we're going to hear experience from Finland, followed by the experience in Colombia. Then we're going to hear the experience of implementing prevention of diabetes in primary healthcare from India. And then I'm going to finalize with a summary of the existing evidence that I found from Europe. And I hope we're going to have at least 20 till 30 minutes then for discussions, for questions to be answered, where you can write in the chat anytime you're interested in. Good. Without any further delay, I would like to present you to Dr. Lindström. She has a master's degree in nutrition science and a PhD in public health, both from the University of Helsinki, where she also acquired the title of adjunct professor in 2010. She works in the Finnish Institute for Health and Welfare as a research manager and leads the team interventions with 25 researchers and other professionals. She has over 30 years of experience, so it means probably start at the age of 10 to work on it, and prevention of type 2 diabetes and other chronic diseases, with special emphasis in lifestyle and dietary factors. She co-developed the Finnish Diabetes Risk Score, FinRisk, which most of you probably have heard of, which is a simple tool to identify people with high risk of type 2 diabetes, and that questionnaire is used really wide in Finland and many, many other countries. She was the co-coordinator of the Finnish Diabetes Prevention Study and has contributed to several national and international projects aiming to implement and scale up screening prevention of type 2 diabetes in Europe and other parts of the world. Her present project includes several European Union funds, joint actions aiming to implement good practice on chronic disease identification, prevention, and management. She has over 200 peer-reviewed publications, so probably not sure if you have any leisure time for anything else. And the most important, she's a very good friend, and it's really nice seeing you again after so many years. Dr. Lindström, the floor is yours. So thank you for joining.
Thank you very much, Noel, for your kind words. I didn't actually know that you are going to read the whole description. It sounded a little bit weird. Can you now see my, let's see. So now let me know, Noel, if you can see my slides.
Yes, all perfect. I can see the slides.
Yes, we can see
Yeah.
the slides.
Great. So thank you again for having me here today to talk about type 2 diabetes prevention in primary healthcare, especially in Finland. I will say a couple of words about the past, then the present, and a little bit also about the future in the field. But at least in Finland, we cannot talk about type 2 diabetes prevention without mentioning the Finnish Diabetes Prevention Study, the DPS. So the DPS was one of the first studies which really tried to find out whether type 2 diabetes can be prevented by lifestyle intervention. And we started the trial already 30 years ago, has started to recruit the participants. Finally, we had 522 men and women who were overweight, middle-aged, and had impaired glucose tolerance at the baseline. We randomized them to intensive diet and physical activity intervention or control group and conducted annual clinical examination, including an oral glucose tolerance test to identify incident diabetes. And like you probably know, we were quite successful. So we were able to show that we can actually halve diabetes incidence with this kind of intervention. And after we published the main results, we continued the follow-up of our participants, first with clinical visits, and from those or that research, we have published a couple of papers showing the sustained reduction in diabetes risk, and also showed that the participants have been able to maintain a healthier lifestyle. Also, even the intervention was stopped many years ago. And we are presently conducting follow-up of these participants through healthcare registers, and those results will also be published soon. So in DPS, the intervention really was quite intensive. So we had individual counseling sessions face-to-face delivered by nutritionists, 7 of them during the first year and every 3 months thereafter for the duration of the average 4-year intervention. We had specified goals regarding to diet, physical activity, and weight reduction. But when we were discussing with the participants, we of course talked about ways to increase physical activity, ways to modify their own diet, make substitutions, what they should increase in order to achieve the goals of the diet. And after we published the quite good results of the DPS, the Finnish Diabetes Association actually took action immediately. They started the Fin D2D study or project aiming to implementation of type 2 diabetes prevention in healthcare services setting. And that project took place between 2003 and 2008. And it was really a quite large project. The target population within the areas participating in the project was 1.5 million of the 5 million at the time we had inhabitants in Finland. And more than 300 primary healthcare service providers took part in the project, at least in some level. Then a little bit about the results and outcomes of the project. So about 10,000 people at high risk were reached and took part in the interventions provided by the healthcare services as part of their normal everyday work. And of them, about 2,800 were included in the evaluation data collection. And we saw a quite modest weight reduction of 1.2 kilos after the 1-year intervention in the project. In the DPS, the weight reduction was about 5% during the first year. So compared with that, quite a modest result. But the mean number of intervention visits was only 3 compared to the much larger number in DPS. And these visits were also mostly individual visits conducted with primary care nurses who were trained to deliver the intervention. And an important outcome from this project was the establishment of new ways of collaboration. So there were care paths defined, including also the risk identification and prevention. There were multi-professional teamwork, started in the participating organizations, and new ways of collaboration between hospital districts and other healthcare service providers, municipalities, NGOs, pharmacies, and research organization like the organization I am working in. And last but not least, models of risk screening and lifestyle intervention were proven feasible in primary healthcare. And one of the important tools that were created during this project was the Find Risk assessment form. So even though it was created already 20 years ago, we have actually validated it quite recently in a more recent data set and shown that it's actually still a very useful tool to identify people with high risk. And therefore, we were quite pleased to see that this year's theme of the World Diabetes Day, which was actually last Tuesday, it was Know Your Risk, Know Your Response, and our Find Risk was there in the core of this multinational campaign. But then moving forward in history, the next big endeavor we conducted in the field of type 2 diabetes prevention was the Stop Diabetes or Stop Dia project. It was actually a randomized controlled trial conducted within primary healthcare in 3 areas in Finland, and it was funded by the Academy of Finland. So it was basically a research project. But our main aim in the project was to create a sustainable model for type 2 diabetes prevention in healthcare, create tools that could be usable also after the project. We used modern digital tools for recruitment and intervention and evaluation, and the lifestyle intervention had very strong theory base. So we had an online risk identification site set up. The risk was based on either Find Risk or previous gestational diabetes, or previous impaired glucose tolerance or impaired fasting glucose. And of these at-risk people who were identified, about 3,000 were invited to baseline measurements, and 2,900 people were randomized to the 3 different intervention groups. So we had a digital intervention, which was basically a mobile app that would support the participants in adopting healthier lifestyle by implementing tiny habits related to different lifestyles. In addition to that, we had another group who had group intervention. This group intervention was also conducted in the primary healthcare and provided by the primary healthcare nurses who were trained to conduct its intervention. It had 6 intervention visits during the first 6 months of the project. And then we had a usual care control group. An outcome evaluation for this study was conducted after 12 months. But already from the beginning of this Stop Dia project, we understood that the recruitment for this kind of large-scale project would be a very crucial step. Therefore, we studied the marketing research, utilize message framing, persuasion techniques, and multiple communication channels in order to reach our target group. So our main message in our communication was take control of your risk, kind of emphasizing self-efficacy already there. Then we advised or prompted the people take the test, kind of gamification going on there. And finally, we told them via this screening site and via the communication that you might get into the study, which it would be seen as an incentive or emphasizing scarcity of this opportunity. And as we had these online screening sites, we could actually follow day to day how the visits and the risk screenings accumulated from day to day. And every time we conducted some kind of communication activity, had visibility in media, in television, or other did some other campaign to reach the target group, we could see a kind of a lump on this curve. And we were able to reach about 15,000 people at risk in these study areas. And of them, about half was interested to take part in this kind of preventive activities. So if somebody says that people are not interested, so I would say that they are, if they are offered some services. Then jumping to the results of the study. So as this was only 1 year trial, we of course didn't expect to see any change in or difference in diabetes incidence. So instead, our primary outcomes were body weight, glycemia, and lifestyle. And we did see a modest improvement in the diet quality of the digital and group intervention as compared to the control group participants, but no difference in total physical activity or sedentary time. We also saw a modest reduction in waist circumference in the digital plus group intervention versus the control. Also, fasting insulin improved modestly in the digital and digital plus group intervention, but we did not see any change in fasting glucose or HbA1c. So I cannot say that I wouldn't be a little bit disappointed in the very modest results that we achieved, but we can of course contemplate a little bit about why was StopDIA not even close to as effective as the DPS study. So of course we had only 1 year intervention as compared to DPS where we had 4 years. We had moderate risk participants, and in the DPS, everybody was at high risk with IGT. And also the intensity of the intervention probably was not enough to induce real changes as compared to the high intensity in the DPS study. Then what is the situation with diabetes nationwide? These graphs are based on register data, and the type 2 diabetes is marked in red. And as you can see, when FIN-D2D was active, actually the incidence of type 2 diabetes kind of skyrocketed there. And maybe somebody could say that the effect is going to the wrong direction. But of course, we know that this is the effect that when you do screening for risk, you also identify people with undiagnosed diabetes, which is a good thing when they then can be directed to treatment. We don't know what your situation is at the moment. The next results are coming in a few weeks. But I am a little bit afraid that especially the pandemic might have a very maybe negative effect on diabetes also, because there are also already some suggestions that obesity rates are going up. Finally, we are at the moment in the middle of the biggest reform in our healthcare services in Finland ever. Since the beginning of this year, the organization has been changed altogether. We have new well-being services counties instead of the previous municipalities. And as you can see in this picture, the aims of this reform are very nice, and you can see lovely words as like better quality and effectiveness, integrated services, equality, and also preventive work is mentioned there as one of the goals, and cutting down the cost, of course. The bad news is that already we know that next year the budget is 1.5 billion euros over what more than what government will give to well-being services counties. And I am very much afraid that this will lead cutting down preventive services. So as conclusion, we know that lifestyle intervention is effective in diabetes prevention. We know that people want to take part in preventive activities, but the sustained implementation of the research finding has proven to be quite challenging. I would hope that the decision makers could see prevention as an investment rather than an expense. The pandemic may have long-lasting effects. We know there are delayed diagnosis, and this increasing obesity rate is a concern. And finally, of course, diabetes is not only a problem of healthcare services. The actions are needed at all societal levels. So we need health in all policies also here. Thank you.
Thank you very much, Jana, for the excellent presentations. Before I'm going to hand it to my co-moderator, Dr. Gupta, just as a small change. Dr. Ashner and Dr. Sabu asked if you can present first. So I hope this is okay for you. And with this, I'm going to hand over to my co-moderator, Dr. Gupta, from our Public Health and Epidemic Interest Group, and who invites us actually all to India probably in January. And we're going to meet them again in August for the World Congress on Prevention of Diabetes. Dr. Gupta, please take it from there.
Yeah, thank you, Dr. Noel. And I'm really thankful to you for this wonderful setting up this wonderful webinar for the ADA and all the organizations which are there. And now I welcome Dr. Bansi Sabu. Dr. Bansi Sabu is currently the chair-elect of the IDF Southeast Asia. He is also the past president of the RSSDI. He has headed many organizations like IRO, that is Obesity India, as well as he has headed Diabetes India. So I will request Dr. Bansi Sabu to talk about prevention of diabetes in primary healthcare setup in India, and what are his experiences. So I think it will be useful for each one of us. Over to you, Dr. Bansi Sabu. Welcome.
Thank you, Dr. Amit, for kind words. Thank you, Noel. Thank you, ADA, for this wonderful opportunity. Let me share my screen. Is my slides are visible? Okay.
Yes.
Okay. So once again, thank you for this wonderful opportunity. What I'm going to talk the primary care, the prevention of diabetes at primary care level. We don't have much work, but still in next 15 minutes, I would like to present whatever we are doing. First, very important thing, that why should we prevent diabetes? And this very important question when we are talking to our primary care physician, we're just trying to explain them that is improve the quality of life, to reduce human suffering and reduce the number of hospitalization, reduce mortality from diabetes, and prevent sudden cardiac death. What we know about type 2 diabetes prevention, that One thing, it's a major challenge to human health. It can be prevented. Now, this important question is why we are asking our primary care physician as well as to the general public, that many person they feel that their parents are diabetic and they are going to develop diabetes. But we have to talk that yes, type 2 diabetes can be prevented, and it is an affordable and a suitable choice, and that's very, very important. It's lifestyle intervention which can be very effective in diabetes prevention. Where we have to do this primary prevention, those who are normal, no, rather than those who have impaired glucose tolerance or those who have IFG. But to detect them is really very difficult. Rather, we go for the people who are already at the risk of developing diabetes, those who have Indian diabetes risk score which is high. On those people we try to prevent them diabetes also. Why this prevalence is increasing? Aging of the population, urbanization, but more in my country it is more sedentary lifestyle. They are becoming fatty, they are becoming centrally obese, and that's a very important reason. And again, at a primary care level we have to explain this, we have to teach them, we have to educate them that why this prevalence is increasing, and that's very much possible that we can prevent. This is one very important data from our country, that we had done a data from 2006 and then in 2016, and just to try to find out that where they are increasing. It is the vast circumference which is increasing in our country, and that's a increasing of central obesity was the significant cause for increasing prevalence of diabetes. So if I see every 10 years the data from 96 to 2006, from 2006 to 2016, this data show that there is an increase in central obesity is a significant cause for increasing prevalence of diabetes. This is our Indian diabetes risk score. Currently, we are already doing a diabetes awareness program for 100 days for 3 months across the country. Those who are at the higher risk, we screen them. If they have IGT, IFG, or even they don't have, we try to educate them. For that, diabetes can be prevented. Otherwise, they are at the higher risk of developing diabetes. And this is what we are doing: mass screening, population-based screening, even selective screening. Those who are ever in the higher risk, and opportunistic screening in our clinic. Also, at a primary care, we educated them that anyone who is coming to your clinic, the way we are checking other vital signs, the pulse, blood pressure, respiratory rate, and the temperature, the similar way, the sugar should be monitored for each one who is coming to your clinic. We know that impact of lifestyle on a diabetes prevention and control can be done significantly. It's not only the nutrition and physical activities, mental health is equally important, because the stress also increases the risk of diabetes. Where we can do the intervention for primary prevention program, whichever has been done, those who have been already diagnosed with pre-diabetes, IFG or IGT, these are the major primary studies in diabetes prevention from all over the world. As we had talked about the Finland, already she had talked in 2001. Then there was a study in 1997 in China, in a diabetes prevention program in 2002 in USA. There was a Japan program in 2005, and this was a program of IDPP, which is Indian Diabetes Prevention Program, done by Dr. A. Ramchandran et al. I'm sure many of you know him, in 2006. And these are the different programs. All of them had talked that meta-analysis of all these 8 clinical trials evaluating the impact of diet and exercise on the risk of diabetes, including among those who are at the high risk population. And these all studies had shown, whether you talk of DPP or whether you talk of Indian diabetes prevention program, it is the lifestyle, diet, and exercise have significant impact for reducing the risk of developing diabetes. Even not only, there are many this program which has been done, and this one already been discussed about the Finnish diabetes prevention study, but there are some anti-diabetic agents were also used to prevent the diabetes. This is one paper which is studied to prevent non-insulin dependent diabetes, which is stop NIDDM trial, where they had used benefit of alpha glucosidase inhibitor. They had used even the glitazone, that's a dream trial, the rosiglitazone, which was a diabetes reduction assessment with ramipril and rosiglitazone medication, which had also shown reduction in the prevalence of diabetes. Even those patients in ACT now study, where pioglitazone was used in the patients for prevention of diabetes. But this had really changed the way diabetes prevention program was there, because diabetes can be even reversed. Because this paper of direct trial had talked about more than 15 kg weight loss in a person with newly diagnosed diabetes, maybe lesser than 5 years. A diabetes can be reversed, and this had increased awareness across the world that diabetes, when it can be reversed, definitely it can be prevented. And now the persons who are at the risk of developing diabetes. Those who are obese, overweight, or even centrally obese, if they lose their weight, there is definitely risk reduction for developing diabetes. In real world, there are many challenges. Even we know that this all is being done. We are educating our primary care physician, but still scaling up these efforts to reach large number. We have 1.4 billion population. We have more than 100 million persons who are already with diabetes, and estimated number of pre-diabetes in our country is 136 million. We have more than 235 million people who are in the risk of developing diabetes in our country. So it's really very difficult to make it effective, especially with less personal involvement, how we can reach out to all these people. And a strategy which could be help for better adherence and sustainability, that's a real world challenge in our country. This is one program which has been done again by the same group, Dr. Ramchandran group, the effectiveness of mobile phone messaging. And that's how we thought of that we can reach out to those who are at the risk of developing diabetes in prevention of type 2 diabetes. The idea was the lifestyle modification in people with who are at the risk of developing diabetes. It was a randomized controlled trial. It was SMS, a simple SMS which was sent to the people to whom we want to intervene, the population who are the interest, or those who are high risk or IGT. The randomization was done with the intervention group and the control group. The intervention group was done standard care with a motivational text message. It is being followed up for 2 years, and every 6 monthly they were visited and then they were analyzed. And the recruitment study had shown after 2 years, the data had shown there was a significant benefit. The personal feedback from the subject for change in frequency, time, and type of text message, storage of participant details, frequency, type, and time on TTM tailored text message on a lifestyle modification, and then this was delivered to these people. It had shown a significant improvement, and the risk of developing diabetes in the intervention group was significantly reduced. This post-trial analysis of Indian SMS diabetes prevention study had shown persistent beneficial effect of lifestyle intervention, which was published in Diabetes Research and Clinical Practice, which is official in IDF Journal in 2018. One more simple, a mobile technology to promote sustained lifestyle changes to prevent type 2 diabetes in India and UK. This program was with Imperial College of London, from the same group, IDRF. We have taken the patients from UK, NHS health checkups, as well as the people with the population of towns of industries, government setup, and township. We screened the people who were having HbA1c of around 6 to 6, which are pre-diabetic population. We also have the patient with less than 6 and HbA1c more than 6.5. For those who are having HbA1c of 6 to 6.4, 2094 were randomized, and then they were given a standard care, and 147 people were given standard care plus intervention again by the SMS. And this pragmatic and scalable strategy using mobile technology to promote sustained lifestyle changes to prevent type 2 diabetes in India and the UK. This was published in Diabetologia in 2019. And this program then ultimately we have taken to the Ministry of Health and Family Welfare across the country, that whether we can use the similar program for AM diabetes program with the help of World Health Organization across the country, to reach out to the primary care, to reach out to the ASHA worker, to reach out to the community health worker, and we can reach. But still, the objective was very clear, that to test the feasibility of reaching and categorize the large number of people, because in India we are the highest user of mobile, to enhance the healthcare seeking behavior, to improve adherence to drug, lifestyle changes, and self-care. The implementation is scope of scale up of this program. The conclusion from M diabetes program in India, it is possible to reach out a large number of people using mobile technology with very little effort. So it's a really a very effective program as well. But it is possible to identify and categorize people as having diabetes and those who are at the risk by the remote method. Improvement in response and sustainability need to be tested by promotional activities and continued efforts. Outbound calls, IVRS, email, mobile application to be tried in the future projects to improve the response from the participants in a large national program done by the Ministry of Health. And this was again published in a improvement in diet habits independent of physical activity helps reduce the incident diabetes among pre-diabetic Asian Indian men. So even a diet alone, I mean, both the lifestyle modification, only diet and only exercise, even with this SMS service or this mobile health service, we could change and improve the diet habits to decrease the risk of developing diabetes. This campaign, which we have done under RSSDI when I was president, defeat diabetes testing, tracking, and treating. In 100 days, we reached out to the 100 million people in India through social media, through SMS, through WhatsApp, in a different way on social media, as well as through online too, and to reach out these people, trying to find out that we decrease or prevent the diabetes, identifying the target population, those who are at the high risk, those who are close communities, healthcare workers, at a national program to make it most cost effective, acceptable, and sustainable strategy. AM health program can support at all levels. But there are major components of any effective prevention program is standardized data collection, a disease magnitude, risk factor, and mortality statistics, clear action plan with specific targets and a well-defined evaluation, initiating community-based intervention for primary prevention, advocacy for influencing policies, advocacy for the rights of people with diabetes, for quality care at all levels, establishing acceptable standard for healthcare for people with diabetes, establishing an effective referral system and defining the role of each level of healthcare, educating the population about this important global epidemic, provision of appropriate training for healthcare providers, and coordination of prevention efforts. Central issues in type 2 diabetes prevention program, there are a lot of issues are there because to reach out these to people, there are so many psychosocial responses also. They are responsible. The policy opinion option to influence diabetes risk is like taxation, food and menu labeling, engage private industry, crop subsidy policy, incentive, promotion of community availability, affordability of foods, incentive, promotion of community support for physical activity, regulation of foods in public area, and school food and physical education policy. Now, all these requires a lot of advocacy at the level of government, and that's real difficult for clinician to reach out to these people for prevention program. The obstacles and barrier for prevention is economic problems, unavailability of needed resources, socio-cultural problems, lack of data and knowledge and skills. The socio-cultural barrier is one very important thing, that obesity is not considered negatively, and this is very common in our country. Fad food culture has caught up. Changing diet is very, very difficult. No value given to physical exercise, no time for physical exercise, those who are at work, and fatalism. So these are the important socio-cultural barriers for prevention program. Also, just now, a national program for prevention and control of diabetes and cardiovascular disease and stroke is being introduced in our country, which is India response to the growing burden of these non-communicable disease. And these are the different activities which they are doing: the health promotion, early diagnosis, case management, capacity building, and management and monitoring. So all these things are done under the program of NPCDS. And what we are trying to do is, we are trying to increase the awareness and trying to put them in action, and then action should go for the maintenance, because the most difficult part is to get the people to prepare and to get them for action, but the maintenance is the most difficult part of this behavior change. We can change the natural history of type 2 diabetes. Definitely we can prevent the diabetes, we can reverse the diabetes, and that's what we have to teach and educate the people who are working at the primary care level. We should intervene early to prevent both diabetes and cardiovascular disease only by simple intervention of lifestyle, that's diet and exercise, if we can do. With this, I thank once again ADA, I thank Amit and Noel for giving me this wonderful opportunity. Thank you very much.
Thank you, Dr.
you.
Bansi Sarabu, for the wonderful presentation. And it is really nice to know what is happening in India for the prevention of diabetes at the primary healthcare level. And I will request all the attendees, if you have any questions, please post your questions in the chat box. There's an option to ask the questions, and we can take the questions from the panelists at the end of the talks. Now, thank you, Dr. Bansi, again for your presentation. Now, I will request Dr. Noel to introduce Dr. Pablo, who is another, he is known for his phenomenal work in the field of diabetes prevention. So I will request Dr. Noel to.
Thank you. I mean, It's a pleasure for me to present you Dr. Professor Pablo Ajner, who is an associate professor of endocrinology at the Javeriana University School of Medicine. At present, he's also director of research at the San Ignacio University Hospital and the scientific director of the Colombian Diabetes Association, Bogota. He graduated in medicine and surgery from the Javeriana University in Bogota in 1974, and undertook postgraduate training in international medicine and endocrinology at the Military Hospital in Bogota and at Cambridge University in the UK, qualifying as an endocrinologist in 1982. He also has a master's degree in clinical epidemiology. His main research interests include diagnosis, control, and treatment of diabetes, epidemiology of diabetes and its complications, as well as the metabolic syndrome in Latin America and the role of diabetes associations in primary healthcare. He has authored or co-authored over 90 abstracts, articles, book chapters in the field of diabetes research, and he's a member of numerous societies, including the Latin American Diabetes Association, the Pan American Endocrine Society. He serves as a member of the World Health Organization Expert Advisory Panel on Chronic and Degenerative Diseases and the WHO Ad Hoc Diabetes Reporting Group. He's also the past president of the Colombian Endocrine Society, the Latin American Diabetes Association, and the Latin American Diabetes Epidemiology Group, and is currently president of the Latin American Group for the Study of Metabolic Syndrome, and serves as chair of the IDF Task Force and Guideline. That's an impressive professional background. And I assume Colombia is still celebrating the great victory of Brazil of last night. So I'm glad you accepted our invitation to join this webinar. Please, Pablo, go ahead.
Well, thank you, Noel, for this kind introduction, and for inviting me to be here with all of you discussing this topic, which I think is very relevant nowadays. As we know, the prevalence of IGT, and this is our data from the last IDF Atlas, is very high. And if we look at the comparison between the prevalence of IGT, impaired glucose tolerance, and the prevalence of diabetes, at any level of income, high, medium, and low, and the same happens in Colombia with our local data, we can see that the prevalence of IGT is either the same or higher than that of diabetes. So we have a huge problem here of people queuing, as if we could say, to become diabetic, to become people with diabetes in a very short time. So this problem has to be addressed urgently and at a global perspective. We know already by the clinical trials, and Jana showed us the DPS, and it has been also mentioned all the other clinical trials, which have shown that actually next to bariatric surgery and glitazones, the life changes, diet and physical activity have shown to be the most effective, with a reduction in the risk of developing diabetes of over 50%. So this, in clinical trials, again, has been shown. This is the evidence. But can it be reproduced in real life in low-income communities? Banshee already showed it can be reproduced in countries such as India. And our question was whether it can be reproduced in Colombia. This is the first study that was done in 2011. And our chairman was involved in this study as a main investigator together with Professor Tommy Leto. And the objective of this study was to demonstrate a demonstration project on the primary prevention of type 2 diabetes with early lifestyle interventions in people at high risk. That means people with prediabetes, compared to those who received standard usual care. So it was a controlled study, and it was done in Barranquilla, which is one of our main cities in the Caribbean coast, the biggest city in the Caribbean coast. And people between 34 and 69 years of age in Barranquilla were screened using the FIN-RISK. So Yana, yes, it's being used globally. And those who had a score over 13 were invited to for an OGTT. A bit more than half of them accepted. There was a 13% people with type 2 diabetes, which was unknown. And there was a 28% of the people who had IFG or IGT or both. That means people with pre-diabetes, and the rest had normal glucose tolerance. So this group with pre-diabetes was randomized to lifestyle intervention or to become a control group. And the people on lifestyle intervention group were randomized to workshops and individual sessions on nutrition or exercise. That means at the beginning, one group was randomized to nutrition, the other group to exercise, which included, the exercise group included dancing, which is one of our favorite sports. And it was given by specialists during the first year. At 6 months, there was a crossover in the groups. So those on nutrition went to exercise sessions and vice versa. And during the second year, because this was a 2-year study, both intervention groups attended workshops on nutrition and exercise every 3 months, so less intensive. And the control group received general lifestyle recommendations. The interventions were similar to those used in the DPS and the goals also. That means at least a weight loss of 5%, fat intake was reduced, saturated fat was also reduced, and fruits and vegetables were increased daily. And the calculation of sample size was based on recovery from impaired glucose tolerance. It was not aimed to demonstrate a decrease in the incidence of diabetes because the time was short. And these are the number of randomized people in the different groups, and those who completed the 2 years, which was around half of them. The incidence of diabetes was not significantly different between the intervention groups and the control group. The risk of relative risk of type 2 diabetes was not significantly different between the intervention and the control group. Neither was the recovery to normal glucose tolerance. It was not significant between intervention and control. So there wasn't really a decrease in the incidence of diabetes that could be proved, or higher recovery from normal glucose tolerance. And these are the status of at 2 years in the different groups of people with diabetes, people who remained in pre-diabetes, and those who became normal based on the OGTT. It's not really discouraging because all the groups had a decrease in the blood glucose. And what seems to have happened is that the people in the control group also improved in their blood glucose. And we could call that a positive contamination between groups, so that the control group also did some changes in lifestyle. And maybe also, obviously, that the intervention group did not reach the goals that were set. So based on this, we decided to evaluate whether this contamination, this positive contamination in terms of lifestyle changes would extend to the whole community when one started a prevention program in the high-risk group. And so we did this. We are just finished this quasi-experimental study to evaluate the feasibility and effectiveness of lifestyle modification program and the control of cardiometabolic risk factors, which we also measured in people with different levels of risk, both in Barranquilla, where the previous study was done, and also in Bogota, which is our capital city. They have some differences in many things, including the geographical setting. Barranquilla is in the Caribbean coast. Bogota is high in the Andes, up to 4,600 meters high. So the climate is different, the geography is different, but still we wanted to see how this works in these two communities. And so we also screened with FINRISK, but we did a modification. We call it FINRISK Latin America because we did a previous study showing that our waist circumference measurements were different to those used in the original FINRISK. So we modified it and actually validated it. You can see down there which are our cutoff points. For men, it's 95 centimeters. For women, it's 90 centimeters. So using this modification, we screened almost 4,000 people, and half of them had a FINRISK above 12 points, which we used as our cutoff point. And we invited them to an OGTT, and again, around half of them accepted the invitation. We had a 5.5% people with type 2 diabetes who were not identified previously, and almost a 14% of people with impaired glucose tolerance, which were those we considered really high risk. And we intervened them with a structured program, which was similar to that established by the CDC in Atlanta for as part of the National Diabetes Prevention Program. We calculated we needed around 153 people in this program to show a significant change mainly in weight along 1 year. This was a 1-year study. The rest of the interventions were community programs and in the community, and we also evaluated their impact in those with moderate and low risk, but this hasn't been analyzed yet. So I'm just going to show what happened with the high risk group. The intervention, as I said, was based on the program used in the US for Hispanics, which was adapted by Betsy Rodriguez and her group. It's called Prevenga Type 2, and it has 26 sessions lasting 1 year. For us, it is too long and too intense. So we adapted it with their permission for our study. So it would last 6 months with 10 group sessions. And the sessions were led by community coaches, which were trained by our group, our research group. And we also used contact using mobile phones, but the sessions were face-to-face. And the main outcome, as I already mentioned, was weight loss. And also we evaluated the glycemic status after 1 year. So a bit more than a half completed the structured prevention program, around 57%. You can see their basal characteristics. And what we found was that at 1 year, the mean change in the whole group of those who finished the program was 2.4 kilograms, which, by the way, is a bit similar to that data, the data found by Lana in Finland. And 78% lost weight, a mean of 3.9 kilograms, and 21% of the group lost at least 5 kilos. And the glycemic status at 1 year, 63% reverted to normal glucose tolerance and 9.6 progressed to diabetes. We don't know if that's less than expected or not, because we haven't had an idea yet, a study to show how many people with high risk, particularly with IGT, progress to diabetes. It was a bit less than what was shown in the previous study in Barranquilla, and a bit more than was shown in that study in the control group, but the difference is not significant. We cannot conclude definitely that this was less or more. Probably more or less the same. So our conclusions is that the primary type 2 diabetes prevention interventions with lifestyle changes are feasible in real life in low communities, because the communities we chose both in Barranquilla and Bogota were low-income communities. And most of the real-world efforts have succeeded in reducing weight and reversing to normal glycemia, although it may not be enough to prevent type 2 diabetes. We don't know yet. Results might be obtained with less intensive interventions adapted locally for people with higher risk, mainly with IGT. And something I believe is important is that the interventions can be given by trained local coaches, avoiding the deployment of healthcare providers who are actually involved in diabetes care where the burden is already high. We cannot just add to their tasks the prevention of diabetes. They are already fully involved in with people with diabetes. So we need a different approach. We need to train local coaches, people who are not necessarily healthcare providers. This seems to work, at least in this study. And screening for type 2 diabetes involves finding people with very high risk who must be incorporated to a prevention program in place. So if we want to start screening for people with type 2 diabetes, we have to have these prevention programs in place and be sure that they do work, at least in changing lifestyle. And the main barrier is, I believe, adherence. More than 50% of the people do not finish these prevention programs. And therefore, this needs a lot of research, as was also shown by Banshee in India. So I think this, for the time being, is enough, and I thank you for your attention.
Thank you, Dr. Pablo. And it is really wonderful to learn the experiences from Colombia. And this webinar is really setting the tone for understanding what is happening in the space of diabetes prevention. Very, very thanks to you for bringing us to this kind of gathering. Now I will request Dr. Noel, and it is a pleasure to introduce Dr. Noel. Dr. Noel is currently working as assistant professor at the University of Florida at Hubbard Witherham Medical College. He has received his training in Finland. He has done Masters of Public Health. He has more than 80 publications to his credit, and he has written multiple chapters. And nonetheless, he is also currently the chair of the Public Health and Epidemiology Interest Group of the ADA. So I will request Dr. Noel to please proceed with the presentation.
Thank you so much, Dr. Gupta, and thank you everybody for joining our webinar. And the next 10 to 15 minutes, I'm gonna summarize you the experience on prevention of type 2 diabetes in primary healthcare, the experience from Europe, whatever I was able to collect and I remember by participating in many of the projects in collaboration with Diana Lindström, who's here as well. So I'm gonna go through the day plan project first, and then follow up an image project, and then some other experience I found when revising the current scientific literature. To talk first on the D-Plan project, the diabetes in Europe prevention using lifestyle, physical and nutrition intervention was probably the very first European or large-scale project that tried to implement the diabetes prevention study conducted in Finland that Dr. Lindström explained to you on a large scale in Europe. It was a project funded by the European Union, which means 50% of funds came from the European Union, and the other part was like in kind by the different partners. It included close to 20 different partners in about 18 different countries in Europe. As most of you know, Europe has a lot of countries. We didn't manage to cover all of them, but at least a lot. Some countries had 2 centers, others participated in 1 center. But important was that for the European Union Agency in Public Health, they do not want to see research, they want to see implementation, which is somehow a bit funny because even if you implement findings, you have to do some research, some evaluation of whether you're successful implementing the findings of basic research or trials into primary healthcare. But this was the first probably ever large-scale project in Europe, and the DAY plan had 3 main objectives. The first objective was screening activities using the Finnish diabetes risk score, screening for people at high risk of type 2 diabetes, followed by lifestyle intervention, so using the DPS program in those at high risk for type 2 diabetes. But they also had a objective or aim to test the feasibility and the cost effectiveness of these programs in clinical settings of primary health care. These are the 3 main objectives, and how this was done is summarized in this figure, that the first step was like using the Finnish diabetes risk score on a large scale, and we chose a cutoff score of 15 points or more. And I know the cutoff score, I mean, we can reduce it, increase it, or reduce it. It has impact on sensitivity and specificity, but we used at that point 15 points or more. So if they had more than 15 points or more, these patients or people in population were invited for an oral glucose tolerance test according to the WHO guidelines. And according to results, if they were identified having screen-detected diabetes or previously undiagnosed diabetes, they were referred to specialist care, so the endocrinologist or primary healthcare physicians who take care of patients with diabetes. Those who had impaired glucose tolerance or impaired fasting glucose or had normal glycemia but still were at high risk, they were invited to take part in the interventions of the DAY plan. So the next step was then offering these interventions. I can see here on the lower part of the figure on the left-hand side, the participant has 3 options, either self-managed assisted interventions, group-based interventions, or individual-based interventions. And the participating centers had the liberty to choose what could be offered. Some centers offered individual and group-based interventions, other only individual, other only group-based. So the centers were able to choose what's best for their system, for the structure of the primary healthcare. The main idea was reducing body weight, increase physical activity to 30 minutes every day on most days of the week, increase fiber intake, but also decrease like fat and saturated fat intake in their meals. The additional component was that trying to maintain compliance, as Dr. Ashner mentioned, that one of the challenges like compliance with interventions, and I agree. So this was tried to achieve by motivating counseling, phone calls, written information, quality controls, and different methods in order to maintain the participants like within the interventions. If the new interventions developed like diabetes, they were sent to specialists. If no diabetes consulted, at least they regularly had an update, a follow-up to see how they're dealing in regard their diabetes risk. Sometimes, I mean, this is the theory, the practice sometimes looks very different, but this is what the whole project aimed to achieve. In the first years, there were a bit more than 200,000 Finnish diabetes risk scores distributed. About close to 10,000 people were identified at high risk and invited to oral glucose tolerance tests, and the numbers of people in the intervention in the end was around 6,000 people throughout the 20 centers we had in the project. even though the idea was not to develop a research project, some of the centers actually managed to sort of to mask the intervention within a trial setting or a pragmatic trial setting. One of these is a center in Catalonia in Spain, in Barcelona. They include about 500 people in primary healthcare in different primary healthcare centers. They had a control group. They used standard care or standard advice, and they offered two types of intervention. One was a group-based intervention, and the other was an individual intervention. For the purpose of this paper, they grouped together the group and the individual-based intervention, even though they had slightly different outcomes. As expected, both the group-based and the individual intervention, they did well, they're better than control group. The individual intervention did better than the group control, the group-based intervention. But if you follow up like the combined intervention group in black and in white, the control group, and this curve shows you people free of diabetes, we can see that after 3 and 4 years, actually there was quite a big gap between the control group, intervention group. So less people in the intervention group developed diabetes during the follow-up of 3 to 4 years. And that was probably the only center that really used some rigorous methodology to see whether the intervention actually works in primary healthcare. Another center in Krakow in Poland, they presented results of 6-month follow-up. So we see the information of 175 participants at baseline, and then at 6 months after intervention has started, they're documented like the total cholesterol decreased in the participants, also waist circumference, weight, and BMI decreased in all study participants after 6 months, as well as systolic and diastolic blood pressure improved after 6 months of the intervention. In some parts, the impact was maybe not that big, but we saw a waist circumference reduction of almost 3 centimeters, which is actually quite a lot. We also usually have to ask ourselves whether these changes can be maintained over time. When they presented the results of year 1 and year 3 of the study participants, and you see there were, out of the 175 participants, they had after year 1 and 3 only 105 left. So again, compliance is probably one of the challenges we face. But they revealed changes at 1 year and at 3 year, actually in weight, in BMI, waist circumference, as well as in HDL cholesterol and diabetes risk measured using the FIN risk. We can also see in this table actually, and the challenge like from baseline to year 1, the changes are actually much bigger in the first year than after. So they sort of start to, the differences start to be less after 3 years than after 1 year. And this is something we have probably observed in other programs as well, that probably there's an initial big change, but then it's a big challenge how to maintain the changes over time. And they basically summarized their findings that the intervention led to a modest weight reduction, favorable cardiovascular risk factors changes, and a decrease in diabetes risk. And some of these were able to maintain a 3-year follow-up. However, not all studies found actually a beneficial outcome. The Hunt study, which is the Norwegian side of a study, they initially about 90,000 people invited to Hunt 3 to their study. 2,380 were in the end included in the Diaplan intervention study. After half a year, about half of them were left, but those who were left of 6 months, they basically finished the intervention at 2 years. So probably the biggest challenge was like getting them within the 6 months, staying in the study. But again, more than 50% were left, probably due to the follow-up. What they showed different results. I just want to show you what we are mostly interested in, probably measuring like of glycemic status. And I showed the HbA1c at baseline, 6 months, 12, and 24 months. In the box A, this is like changes overall in men and women. B is like based on age. C is based on location, and D is based on depression scores. And we can see that actually probably little change in the first 12 months, but they actually increased their HbA1c in all the categories in the study. And they concluded that basic lifestyle advice given to high-risk individuals during 3 group sessions with 6-month interval was not effective in reducing 2 years diabetes risk. That's as a result of a Hunt study. However, in the same country, in a study conducted in Pakistani immigrant women, where they had 100 women in the intervention group and that received the culture adapted intervention, also based on the DPS, and 100 women in the control group, they revealed like statistically significant improvement of fasting glucose levels, fasting insulin levels, triglycerides, and BMI during the intervention. They compared those who participated in 4 or more lessons compared to the control group. So in some population, apparently some benefits were obtained. But again, in total, we had about 150 people enrolled or who were compliant with at least the intervention. After the day plan, then you may recognize some people in these pictures. And so the follow-up project of the day plan was the IMAGE project that was led by the principal investigator, Dr. Schwartz, who was, I think, the IDF president and president-elect. And that project developed several toolkits for diabetes prevention. One was the aim to develop a European practice or the guideline for the prevention of type 2 diabetes, but also having a European curriculum that can be used for the training of prevention managers. It also developed European standards for continuous quality control and evaluation of prevention programs for type 2 diabetes, including an e-health training portal for prevention managers. So the idea of this project was to develop the tools that can be used in primary healthcare for prevention of diabetes. In very short, this is the first publication that we came up in IMAGE was to take action to prevent diabetes, which was a toolkit for prevention of diabetes. The main author was Dr. Lindström, and she may comment upon it in the discussion part if she likes. So there's a large group of authors. I think, again, we were more than 20 centers working together to develop that material. The other was like quality indicators for the prevention of type 2 diabetes in Europe. Again, the publication from the IMAGE project. And a lot of information can probably be found online on that project. But this was sort of a follow-up project, learning from the plan what needs to be improved, and to develop as well like some tools that can be used in primary healthcare. Finally, there are other projects as well existing in Europe, and probably the most cited one could be the Norfolk Diabetes Prevention Study. This was a parallel 3-arm group-based randomized clinical trials, 46 months of duration between August 2011 and January 2019. It was conducted in 135 primary practices in the eastern part of England, and they randomly allocated a bit more than 1,000 patients into 3 groups. The control group that received standard advice, in the intervention group that had 6 core main sessions on diabetes prevention, lifestyle habits, nutritional changes, and 15 maintenance session. What they added is a 3rd arm that used intervention combined with support from diabetes prevention mentors that were basically trained volunteers with type 2 diabetes. What they realized actually that the intervention groups did much better than the control group. So there was a delay of the onset of type 2 diabetes, or partly maybe prevention, but they did not reveal statistics in the differences between the intervention group and the intervention group with the diabetes prevention managers. So adding diabetes prevention managers did not further reduce the diabetes risk. But this was probably one of the biggest trials in primary healthcare that showed that type 2 diabetes can be delayed or prevented. The other one I wanted to mention is the Dutch study in North and East Gelderland in the Netherlands, which was a study that compared as well the intervention based on the SLIM, which was another randomized controlled trial in the Dutch population. They compare baseline levels between the intervention control group at 12 months and 18 months. What they observed was changes or differences in weight, BMIs, anthropometric measurements, waist circumference, as well as fasting and 2-hour glucose levels between the intervention and the control group. They had less people enrolled in their study, but they also revealed some positive changes in participants that participated in intervention, as many also had a little bit of problem with compliance. So these are probably the current most important or cited scientific evidence that we have from European studies. And as you can see there is some evidence throughout Europe on the implementation programs to prevent or delay type 2 diabetes, but there's not that much evidence. And I think we still need to have more studies. I think we still do not do well enough probably implementing the experiences from basic research into primary healthcare and for the benefit of the study population. These studies work well in well-controlled designs and trials, but there is some challenges implementing them in real life. And some of my previous speakers mentioned compliance and issues, the different kind of barriers, and probably we should try to identify the barriers that exist, how and the problems implementing primary prevention, primary healthcare. Most programs are based on the intervention developed by Dr. Lindström and Tuomilehto on the DPS study. I think we need more scientific evidence, not only of the effectivity, but also cost effectiveness analysis. Maybe we should have as well more developed qualitative components, so pragmatic trials may be a good option. A qualitative part of each study, not only the quantitative part. Those trials or studies implemented in primary healthcare should probably measure to our glucose levels as well as HbA1c and fasting glucose, and not only maybe some changes in cardiometabolic or anthropometric measurements. So I think in the endpoint, we'd like to know if we manage to delay prevent diabetes. So we need to measure the glucose values in the blood of the study participants. So I think finally, there's still a lot of things to be done. There's still plenty of work for all of us to work in the prevention of diabetes, especially in primary healthcare, and challenges ahead. So when I started to work in diabetes, I met Professor Tuomilehto. He told me how he ended up. And in the 80s or 90s, he said he's going to start working diabetes. They told him, but we know already everything about diabetes. And then he and Dr. Lindström showed that actually there's a lot of things we don't know, and this continues until now in the future. There's still a lot of things to develop and to work on, but I think we should definitely have a bigger impact on how to implement findings of science into clinical practice. And with this, I conclude my presentation.
Thank you, Dr. Noel, for your wonderful presentation. And you have rightly said that challenges are many, and it is really difficult. The epidemic of diabetes is increasing like anything. And we think of novel strategies, novel ways that how we are going to deal with this epidemic and how we are going to prevent such a large number of people getting affected with diabetes. So again, I can't see any questions in the chat box, but if you have any, you are free to ask the panelists. And I'm really thankful to you for setting up this webinar in this extremely busy week, which is the Diabetes Prevention Week. And you have invited experts from all across the globe, bringing their own perspective on diabetes prevention. So Noel, I will request you to propose the vote of thanks. And I have already thanked you. Now it's your time, because this webinar is brought up by multiple collaborations. It is ADA, it is AMNET, it is Florida International University, and multiple other organizations, AFHA. So I will request you to propose a vote of thanks, Noel.
Okay, thank you, Dr. Gupta. We still have about 10 minutes. So if somebody of the audience, of the participants have a question, you can either write in the chat or you can raise your hand and you'll be recognized, so I can unmute if you'd like to ask a question to any of the panelists. See no questions. We have recorded the webinar, so we're gonna publish it. We're gonna let you know among all those registered. We're gonna send you information on how to exceed the recordings. So if there are no questions, then I would like to thank each of you, the speakers, Jana, Pablo, Bansi. Thank you so much for your time. I know that we're on different continents, and there's different times. I think for Jana, it must be like late evening. Pablo and me are in the same time zone, I guess. It depends where you are at the moment. So, and then I think Bansi, it's about at least 12 hours ahead. Not sure if any of the panelists would like to have some final words of encouragement. No. All right. With this,
well,
yeah,
I don't know if it's, but at least I'm glad to see that we are having the same problems all over the world, and I think we should continue with our efforts to find better solutions, and particularly to exchange our experiences like we have done today, because that helps a lot. Seeing what others are doing and their problems and how they are trying to solve them helps a lot to all of us. So thank you.
Yeah. Thank you so
I
much.
would also like to add that you arranging this meeting and inviting us to talk and listen to each other has been already an encouragement for us, because diabetes prevention has been kind of buried under all the other problems we have at the moment. So thank you, Noel.
You're very welcome. And I think it also encourages everybody to work and find ways how to work in the barriers, and maybe you can even come up with a joint study and have some ideas we can maybe share with you afterwards.
Yep.
All right. Thank you so much for the US people here. Happy Thanksgiving holidays. Most of you start next week. In 1 week is Thanksgiving, so a lot of people probably going to prepare for the holidays. And for Finland,